Good afternoon, I'm Dr. Isabelle Conepo. I am pediatric rheumatologist at Kremlin-Bicêtre Hospital, and I am the head of the Referral Center for Auto-Inflammatory Diseases and Inflammatory Amyloidosis. And I have the pleasure to talk this afternoon on Kawasaki disease. So Kawasaki disease was first described in 1967 by Tomizaku Kawasaki in Japan. It is an acute illness, and it is the most frequent cause of acute vasculitis in children before the age of 5 years. The vasculitis affects the medium-sized vessels and also the small vessels, and the prognosis is essentially cardiovascular. The most important risks are coronary aneurysm, thrombosis, myocarditis, shock, valvular lesions, and macrophage activating syndrome. Death has not been appreciated very exactly, but it's relatively exceptional, and we have only a few studies that have not been made in intensive care units. Most important difficulties in Kawasaki disease are to make an early diagnosis and also the increasing incidence of the disease in developing countries. The other difficulty is a resistance to standard treatment. Standard treatment is IVIG, and there are 20 to 30% of patients who are resistant to this treatment and who have an increased risk of complications. What is the epidemiology of Kawasaki disease? We have to know that first, Kawasaki disease is the first cause of acquired cardiopathy in developing countries. Patients from Northern Eastern Asia are at 20-fold risk of developing Kawasaki disease compared to patients living in UK or in France. And you can see on the right a map of the incidence of Kawasaki disease in Europe, which is relatively low compared to the incidence in Asia. And you can see also that in US and Canada, we have an incidence between 15 to 25 in 100,000 children in these countries. So, what is the presentation of Kawasaki disease? At the initial phase, children present like a viral infection, which may be overt or suspected. They may have rhinitis or cough. They also may have digestive symptoms. In 70% of cases, they may have abdominal pain, vomiting, diarrhea. Some rare patients may have peritonitis and abdominal hemorrhage, and those digestive symptoms may delay the diagnosis and may have a poorer prognosis. During this phase, patients have high fevers, making peaks, and fever is few sensitive to antipyretics. One important thing to recognize is the irritability and the alteration of the general condition. In exceptional cases, 1 to 2%, patients may have a cardiogenic shock at presentations, and this cardiogenic shock is related to myocarditis or to myocardial infarction. So I show you cutaneous aspect of Kawasaki disease. These features are very important to recognize. And so you can see on the left up, you can see the child who is very irritable, is crying, and you can see that he has very dry and cracked lips. And you can see also in the other pictures that they may have diffuse exanthema. In most cases, it's maculopapular. They may have also eye redness, and also you can see that they may have large adenitis. In general, it's more than 1.5 centimeter of diameters, and it really looks like a phlegmon and look like an infection. So just a focus on conjunctival redness, important to recognize that it is bilateral, you don't have any exudates, and also the perikeratotic circle is also something important to recognize. For the cervical lymphadenopathy, it's often unilateral and relatively anterior. Other things that are the modifications at the hands and feet. So during the acute phase, those patients have edema of the hands and feet and also redness of the palms and soles. And at the subacute phase, you can see that they have desquamation at the toes and also at the fingers and the hands. It's very thin desquamation. So other features, you can see that those toddlers are always crying, but the erythema at the seat is something that is relatively early to recognize and may be very useful, and also the redness at the scar of the BCG injection. So you can see here the distribution of the clinical features of Kawasaki disease. Something important to keep in mind that all these features may not be present all at the same time. So it's important to ask the parents if they have seen those cutaneous features, and if they can show you pictures, it is something important. So do not misestimate the presence of these cutaneous tips and just ask for them. So you can see that the median age at presentation is 2.8 years, and that the males are relatively more affected than females. So fevers is almost always present with irritability. Also bulbar conjunctivitis without pus is present in up to 90% of patients. Also the modifications of the oral cavity are very frequent, and also the strawberry tongue, and also the diffuse exanthema and the modifications of the redness, edema of palms and soles. More rare is adenopathy. Only one child on two child may have it. And the digestive symptoms are up to 60% of patients, like hepatomegaly, bladder eye drops, and gastrointestinal disorders. Cardiac findings, you can see that coronary dilatation are the most frequent, and in the French cohort it was up to 40% of patients. But there are also pericarditis, myocarditis, and cardiac failure was present only in 1% of patients. So important to keep in mind are the international criteria to make the diagnosis of Kawasaki disease. It is very clinical, and you have 5 main criteria. So the first one is the dry lips, the raspberry tongue, the redness of the oral cavity and the pharynx. The second one is a bilateral non-purulent conjunctivitis. The third one is exanthema, so all types of exanthema except vesicles and scabs. And also the edema and redness of the hands and feet during the acute phase, and also the periinguinal desquamation in the late phase. And also the cervical lymphadenopathy with a size of at a minimum of 1.5 centimeter, most often unilateral. So you have a complete Kawasaki disease if you have fever of 5 days and 4 among 5 of these main criteria. But you may not have all the criteria, but if you have one cardiac finding, especially one coronary dilatation, you may have a diagnosis of incomplete Kawasaki disease. So you see that diagnosis is very difficult, and so we really need to have an acceleration to diagnose this disease because we need to treat it early. So there have been some propositions from the British Society And they suggest that in the presence of 4 principal clinical features, particularly when redness and swelling of the hand and feet are present, the diagnosis of Kawasaki disease can be made with 4 days of fever, although experienced clinicians who have treated many patients with Kawasaki disease may establish the diagnosis with 3 days of fever in rare cases. And also you have also proposal from the chair, so the European recommendation, clinicians should not delay diagnosis Kawasaki disease and instituting a treatment if 5 out of 6 criteria of KD are present before day 5 of fever, or if there is coronary aneurysms or coronary dilatation. So look at this recommendation, which is in the US recommendation in a patient in whom Kawasaki disease is suspected, but all criteria have not yet been fulfilled. The following clinical signs strengthen the suspicion of Kawasaki disease, and they point out irritability and new erythema and or induration at the site of previous BCG immunization. So there are common pitfalls in the diagnosis of Kawasaki disease, and those ones are the infants of 6 months or less with prolonged fever and irritability, those patients with prolonged fever and unexplained aseptic meningitis, infant or children with prolonged fever and unexplained or culture-negative shock, infants or children with prolonged fever, cervical lymphadenopathy unresponsive to antibiotic therapy, or those infants or children with prolonged fever and retropharyngeal or parapharyngeal phlegmon unresponsive to antibiotic therapy. Also, we have to point out that some of these patients are diagnosed with urinary tract infection, with sterile urine cultures. Some of them are diagnosed with reaction to antibiotics or with acute abdomen, and also in some cases the size of the coronaries are underappreciated because the Z-scores are not used. And so it's important to point out that we need to use the Z-score that use the Montreal normative data, and then you can use these scores, and very easy, you can update an app, CardioZ, that can help you to calculate the Z-scores regarding the gender, regarding the age of the patient, and also his height and his weight, and the size of the coronaries. I show you here that Kawasaki disease has a number of differential diagnoses, and I may ask you in this picture which patients has Kawasaki disease. And I have to tell you that none of them have Kawasaki disease. They have other diseases that really look like, but are not Kawasaki disease. So there is a number of differential diagnoses. First, the viral infections like measles, adenovirus, enterovirus, Epstein-Barr virus, or coronavirus. And in many cases, the viral infection coexists with Kawasaki disease, so it's not exclusive. If you find a viral infection, it doesn't exclude the diagnosis of Kawasaki disease. Another differential diagnosis is scarlet fever or staphylococcal skull skin syndrome, toxic shock syndrome, bacterial cervical lymphadenitis, drug hypersensitivity reaction, Stevens-Johnson syndrome, juvenile rheumatoid arthritis, Rocky Mountain spotted fevers, and leptospirosis. But also other diseases like Still's disease, periarteritis nodosa, leukemia, and also monogenic auto-inflammatory disease, especially mevalonate kinase deficiency or NLRC4 deficiency. So this is a critical situation, so I won't go again through this. So what is the cardiac involvement in Kawasaki disease? So it's not restricted to coronary aneurysms. which are important, of course, because they may be up to 25%, but there is also other features, and especially myocardic dysfunction, which is present at the early phase of Kawasaki disease in up to 70% of patients, but in general, it is minimal and it regresses rapidly. So it is really underestimated. Pancarditis is also possible, and also valvular lesions with mitral regurgitation, and also aortic regurgitation, and in some cases, we may have dilation of the aortic root. So it's not completely restricted to medium-sized vessels. Where are located the coronary aneurysms? In most cases, they are at the bifurcation of the common trunk of the left coronary and the proximal segment of the anterior interventricular and the right coronary. Histologically, we have huge inflammation at first in the antima, which induce dissociation of endothelial cells and subendothelial edema. Secondary, the inflammation reaches the media, and then the media is destroyed and the aneurysm is formed. After this, there is active phenomenon of remodeling leading to fibrosis, then to stenosis. So I show you here some aneurysmal dilation of the interventricular anterior coronary, and you can see that in many cases you may have not only one aneurysm, but really strings of aneurysms. So it's important to classify these coronary lesions and to measure them, because it has really an importance regarding the evolution and the prognosis. So the classification is made in Z-score. So you can consider that there is no involvement if the Z-score is under 2. You have some dilation if the Z-score is between 2 but less than 2.5. You have a small aneurysms if you have a Z-score at 2.5 until less to 5. You have a median aneurysms if you have a Z-score of 5 up to less to 10, or if the absolute size of the coronary is less than 8 millimeters. And you have a giant aneurysm if you have a Z-score of 10 or more, or if the absolute size of the coronary is 8 millimeters or more. And the evolution of the aneurysm depends on different things. First, the size and also the morphology. The complete regression is not in all patients, it's only in 50% of cases, and it's essentially those aneurysms that are small or medium, and it happens during the 2 first years of evolutions. Stenosis appears in 20% of cases. And you can see that aneurysms persist without stenosis in 40% of cases. Unfortunately, giant aneurysms may never regress, and 50% of them go to stenosis or complete obstruction. In less than 1% of children, you may have early death by myocardial infarction, and this is really something to monitor. And you have also to check the other arteries, and especially the axillary, the subclavian, brachial, femoral, iliac, splanchnic, mesenteric, most often at their bifurcation. So this is something important. So this can be detected clinically, and in any depth, you can make an angio-MRI to look at the morphology of these segments. What is Kawasaki disease shock syndrome? It's a very rare event where the patient presents with acute heart failure. So it is defined by the presence of Kawasaki disease plus hemodynamic instability. So it usually occurs in the acute phase of Kawasaki disease, and it is relatively rare. In this category of patients, in most cases, they have a slightly older age than usual patients with Kawasaki disease. They have longer fever duration, and they have IVIG resistance. It's also more prevalent in children who have atypical or incomplete Kawasaki disease features. In this presentation, you have high level of inflammation, which is related to an intense cytokine storm. And you have here some result of the cytokine levels comparing KD shock syndrome with usual KD, and you have really a distinctive secretion of interleukin 6, interleukin 10, TNF-alpha, and interferon gamma. So what is it related to? So even we don't know the etiology of Kawasaki disease, it is suspected that a trigger may induce an intense innate immune system reaction leading to intense inflammation, and then after the enhancement of the innate immune system, there is an enhancement of the adaptive immune system with different consequences. And one of the consequences is the endothelial injury. And the second consequence is a cytokine storm with high level of IL-6 and the interferon gamma that lead to macrophage activating syndrome in some cases, but also maybe to KD shock syndrome and acute myocarditis. So these inflammatory gradients may depend on the properties of the inducing agent, but also may be proper to the level of the host immune responses.